Good morning, everybody, and welcome back to your Lunch Break Live. My name's Savannah Harinkyu if you're new here, and if you're not, thank you for coming back. Today, I think we're going to have a very interesting conversation, and that is one about monoclonal antibody treatment for COVID-19 patients. Today, I am joined by Dr. David Thrasher. Dr. Thrasher is located in Montgomery, where he has about 38 years of experience here as a pulmonologist. So, Doctor, I know we were saying you've seen almost everything you can see, I guess, until pretty recently. But Doctor, you've been pretty outspoken about monoclonal antibody treatment, about how you think this could really be a game changer. So we want to talk about that, get into some questions. But before we get there, let me just ask you, how are things going right now, you think, in the state of Alabama? And how is the Delta variant really affecting the progress we had made against COVID-19?
Thank you, Van. I'm glad to be here. I predicted last November, once the vaccine was announced by Pfizer, that we'd have Independence Day this summer. July 4th, I thought it was pretty smart. I think we had that. The cases went down to almost nothing. Then Delta came to Alabama, and it has been tough. Like I said, it's like Sherman going through Georgia, hard, fast, and taking no prisoners. And that's what it's doing. It's hitting the unvaccinated. This is a different animal, as I say. This is not the same demographics we saw a year ago. These are young people, 20, 30, 40 years old. Rarely do I see a 70-year-old. I got ICU full of 20s and 30s and 40-year-olds on the ventilator. It is hitting them very hard. It's hitting pregnant women very hard. We're overwhelmed all over Alabama, not just Montgomery. We have no ICU beds here. We barely have any beds. The ERs are crammed full of patients on ventilators are sick. It is desperate. I encourage everybody to be super safe. Our staff is sick. I got called this morning. Two doctors came down with it today. The last 5 days, I've treated 11 now providers that come down sick. I'm talking about doctors and nurse practitioners. It's tough.
How does that affect you? I know you were, before we went live, you said that you'd had a really busy morning, and I know you are running you're running raw, and I'm sure most of your staff and most healthcare providers across Alabama are feeling the same way.
Yeah, it's been tough. I've been here since 5 o'clock, and we probably won't get home to probably 10 tonight, and I won't be able to see everybody in the hospital I need to. I've never done that before in 30 years I practice this. It's just an overwhelming volume, and these people are so sick.
Oh, and our hearts go out to those people as well. But, you talk about sick patients, and that is a good time for us to start talking a little bit about this monoclonal antibody treatment. So first, I know you sent me some information. You actually helped out one of our reporters last week with a story about monoclonal antibody treatment, what it is, and how it works. So first, let's just go over exactly what it is and how you get it. So I know that you said when you talk to a patient, you don't even really need to know when they tested positive. You need to know when the first day of their symptoms are. So tell me a little bit about how you go about that first visit.
Sure. Let me tell you how this started. I got called November 16th last year by the vice president of Eli Lilly. They flew to Alabama and kind of educated me over the weekend because we were seeing so many COVID patients there. We got the first monoclonal antibody in Montgomery. We infused the first 10 or 20 people here, then started doing all over the state and then all over the southeast. Now that was the Lilly product called bamlanivimab. It was actually named in honor of Alabama. Alabama is the first part because the developer, the vice president, is from Alabama. We did that a lot. I probably did well over 1,000 infusions then, and that enabled us to survive the surge we had in last January. And we realized then and looked at the data, it was keeping people out of the hospital over 70% of the time and knocked the mortality down to just about zero. So that's what we had then. All right, then Delta came along. And a new monoclonal, Regeneron, that's the one that President Trump got. It's more effective against the Gamma variant, and that's why we're using it here instead of the Lilly product. Now, what I want to do when somebody calls me or texts me or a doctor calls says, I've got it, and they want to tell me when they tested positive, well, I don't really care. I really want to know when their first symptom was. I've got 10 days from symptom one to get you treated. After that, it's too late. The virus is already in your cells, if you will, and it's too late. If you wait until you need oxygen, it's too late. So if I can get you in that, really in the first 5 days is ideal. That's what I try to do. I've got a lot better chance. I got called just a few minutes ago before you called, a lady who is just had a baby, 8 months old, breastfeeding, and she's really sick, and the baby's really sick. I'm going to emergency infuse her today. Now, today's day 8 for her. Later that I won't, but that will help her get sick, hopefully, and also get antibodies transferred through the breast milk to the baby, and hopefully keep the baby from getting too ill. So that's your 10-day window we're talking about, Ivana.
So you really need, this is not necessarily a treatment that you get when you're so sick and you're in the hospital. This is like the first step to not get in the hospital in the first place.
Once you get in the hospital, I don't have a lot of bullets in my gun. If I can get you early and keep you out of the hospital, that's our best bet. Once you're in the hospital, I've got steroids. Well, I got steroids as an outpatient. I've got oxygen in the hospital. I've got oxygen outside of the hospital, not as much like a ventilator, but I got a few other things. We won't talk about Actemra and Illumient and some other ones, but they aren't great. Okay. And once you're that sick and your oxygen level starts falling, I'm behind the 8 ball. Okay. So I really want to get you before you get in the hospital.
So we're going to get, so the point of these is to get ahead of it. So
Absolutely.
What do you need to call? Who do you need to call if you are an average person and you test positive for COVID? Who do you call? Do you call your primary care provider? What if you don't have a primary care provider? How do you go about this? Can you just go to your local urgent care to receive this treatment, or how do you get it?
That's a great question. I sent you my treatment protocol. Now, to be honest with you, there are not a ton of doctors who've treated a lot of COVID-19 patients. So that's the problem. Now, we've sent out, Dr. Mike Sag of Birmingham and the Medical Association have made several videos, webinars, trying to educate the public as well as the doctors about this. I tell people, if you are positive, call your primary care doctor, your provider, whoever it is, and say, do I qualify for the monoclonal? They may say, well, I don't know anything about it, or you don't qualify. They say you don't qualify, ask for why. Okay, because I say if you're over 12 years old and you can walk and talk and live in Alabama, you probably qualify. The qualifications are very, eligibility requirements are very broad. If your doctor doesn't know, I'm going to say call your local hospitals, and hopefully they'll have somebody they can you can be referred to.
And this is kind of one of those cases of you got to be your own advocate in the healthcare system. You have to ask questions and you have to do your own research. So you made a comment about if you are over the age of 12, you can walk and talk, you probably qualify for this treatment. Now, you also, though, in this treatment protocol I've got in front of me, talk about BMI. Now, that is something that I know a lot of people in Alabama are overweight. If you are overweight and if your BMI is not what is considered on the BMI range to be a healthy or in a good weight capacity, do you still qualify?
Well, like I said, you have to be 25 or over on your BMI. And looking at you, you're probably the only one I've seen all day that would not qualify. Okay.
I'll take that as a compliment.
It's very easy. High blood pressure. People have high blood pressure. They have bronchitis. It's very easy. The qualification is very easy. I had rather overtreat this than undertreat. It's extremely safe. And so, if your doctor says you don't qualify, ask him why, And now they may be confused because the BMI requirement for the Lilly product was 35. That's what we call, really big. Okay. So you don't have to be nearly that big. So most people will qualify, and you really want to encourage them to be proactive. Now, I started doing articles a year ago, and I put maybe a dozen plus, gave them to my daughter-in-law to post on Facebook. I've never done Facebook. I don't recommend professionals do that, but there was so much misinformation. And to be honest, we did not know what we were doing. None of us did in the early days. So what we saw first was the too early use of steroids as an outpatient. We were killing people. But doctors didn't know. It's not their fault. So we started, Dr. Zag and I did a video on that last December, warning people don't take steroids the first 6 days. They're great from day 7 on. The first 6 days, your body's making interferon. You don't want to suppress it with steroids. Now, you feel great if you do it, but then you fall off a cliff and can die the next week. on day 7 and 17, your body's making the cytokines, and that's when they start attacking your body, and that's when you want the steroids. So my point being, we started putting this on social media so the patients know what to do. They know not to use steroids the first 6 days. They know to call somebody and ask about monoclonals, even if their doctor had never heard of them. It's not being critical, the doctors never heard of them. It's just a new disease, but I want the public to be educated on this.
Now, a couple questions about these. Now, these monoclonal antibodies we know are synthetically made. What is the difference in getting monoclonal antibody treatment, so these synthetically made antibodies, versus receiving plasma from somebody who has recovered from COVID and getting their antibodies?
Great question. Before we had the monoclonal antibodies, we used what's called convalescent plasma. We used it a lot. Frankly, we even before the studies came out, we weren't getting very good results. And just last week, it came out and says they just don't work. They've tried them in several situations, concentrated, they just don't work. And again, they probably don't work because they're probably given too late also. These things work best in the first 10 days of symptoms. Same thing with remdesivir. That's the first antiviral that was approved. They work better if you use them outpatient, but we can't do that because it takes a infusion every 5 days. So back to your question, the convalescent plasma just doesn't work. We don't use it anymore.
That's interesting, and that's something interesting to know, because I feel like that was such a groundbreaking thing when people first started using it. But we know this virus is changing, hence the Delta virus, the Delta variant. We know that treatments are changing because we're learning more. And that's just kind of the way that this goes. So another question here, and you mentioned this earlier, but I think it bears repeating. Is monoclonal antibody treatment what former President Donald Trump received when he had COVID last fall?
That's a great question. Okay. I know the answer. Okay. There's a lot of treatments out there. You've got them in my protocol. I've talked about what I don't use anymore. President Trump was a big proponent of hydroxychloroquine. We used that like it was giving out candy before we had inpatient and outpatient before we had data. President Trump did not take hydroxychloroquine. He took remdesivir. That's the monoclonal I'm giving you now. He took, Regeneron is the monoclonal I'm giving you now, and remdesivir and steroids. That's what President Trump took.
So what about, you just made that comment about how you don't use convalescent plasma anymore. I've got a question here from somebody that says, so if I am a person who recovered from COVID and I have antibodies, should I still be donating plasma? Is there anything I can do to donate?
Well, thank you for just being that concerned about your fellow man, but no, we don't do it anymore.
Now, another question here on kind of it might be a little bit of something that you've already talked about, so I'm sorry if it is, it bears repeating. If you get monoclonal antibody treatment and you were not vaccinated, you recover and you say, oh my gosh, I should have been vaccinated, I'm going to go get my vaccine. How long do you need to wait between when you get this treatment and when you get vaccinated?
30 days.
30 days. Now, do you also, this is again, something that has changed. When COVID first kind of was hitting us and we first got these vaccines, there was kind of a rule that said, if you got COVID, you need to wait 90 days before you get your vaccine. Is that still the case, or is that window closer to 30 now?
Yeah, we've changed our minds on that as well. Okay. There were several reasons we pushed it to 90 to begin with. Some of the reasons where we didn't have enough vaccine and we thought it'd be better. And you are protected for quite a while if you had the virus or the infusion. Now, basically, if you've been infused, wait 30 days. If you did not get the infusion, probably about 10 days after you are afebrile, you can go ahead and get the vaccine. You don't have to wait 90 days for that.
This is a question I got from Twitter, and this person said, are there any worries about getting other illnesses from the treatment? And he said that he was thinking about these kind of old, antiquated worries about blood transfusions. No.
Simple no. It's very well tolerated. You can have fever, aches a little bit, but you're going to be having those with COVID too. The first trials were in the Lilly product. There were no deaths with it. This is you never say never. Somebody could have whatever reaction, but it's a 20-minute infusion. We watch you for an hour, and it's incredibly well tolerated.
You say 20-minute infusion. Now, for somebody like myself who's not in the medical field, I am not a doctor, nurse, or anything medical. When I think infusion, I think some big process. Is that exactly what this infusion is, or does it look more just like an injection?
Well, you put an IV in, you hang the bottle up, and in 20 minutes it goes in, it takes it out and watch it. That's it. It's not a big deal. I'm sorry.
No, go ahead.
And we also just got approved for the subcutaneous. That's where you make a small injection in your leg or your arm, and we go roll those out to rural doctor's offices that they want to give it. The Medical Association, along with Dr. Harrison, the state public health department, are working on that now. We've had a great relationship with Regeneron. They've been wonderful partners to work. They've guaranteed us we'll have all the product we need. We're not going to run out of the infusions or the sub-Q, and they're helping us get the rural doctors set up so they can do this in their office.
That's a good point. You say that they've said we're not going to run out of it. Since these antibodies are not, they're not made in the blood, they're made synthetically, they're made in a lab. Does that mean that we have much more of a chance of not running out of them?
First question I asked, I said, are you going to make sure I have all I need? And they said, yes. I've asked them that several times. They yes. So they've been producing this for probably close to a year now. So yeah, that's what Regeneron has said, that we're gonna have all we need, and I'm gonna hold them to it. Same thing with Lilly. Lilly did that. Lilly was great. We never had any problem with a short supply.
Got several people asking. This is a great question, saying, "Well, what if I don't have insurance? How do I pay for this? Does insurance cover this?"
Well, yeah, everything's a little bit different, but the drug is free. The federal government has bought the drug, and I think, I'm not an insurance expert, okay, but it's pretty close to free, okay. If you do not let that hold you back, okay. The government pays the provider, the hospital, whatever, a fee for administering it. The drug is free, so. I've done, well over 1,500, and I've not had one person complain. I think it's totally free, but again, I'm not an expert on that, because what you do it's Shelby County and Montgomery County may be a little bit different, but the doctor cannot charge you for doing that. I know that.
That's interesting. And I'm glad you bring that up, because it's similar to questions we had about the vaccine. I remember I had a conversation with somebody that said, well, I'm not going to trust a vaccine that companies made for free. And I said, well, the companies didn't make it for free. It is free to you. That doesn't mean that it was made for free. So it sounds like it's a similar thing here with this monoclonal antibodies.
Correct. It was not free. The federal government bought. I'll give President Trump and everybody a lot of credit. One reason we have the vaccine and these monoclonal treatments is he threw tons of money through Operation Warp Speed, which I've talked to a lot. And so these people were guaranteed that they were going to be reimbursed even if their product failed. That's what it takes to get something in the market quick.
I've got a question here from Anthony, and he says, look, what if I have asthma? Can I have this treatment? So kind of jumping on that question, are there different scenarios where if you have a pre-existing condition such as asthma that you shouldn't get this treatment?
No contraindication to this, unless you had an allergic reaction to it and you used it a year ago. No, if you have asthma, you want this treatment. I'm an asthma doctor, okay?
That's a good point there. Good point to reiterate. Now, also kind of jumping on that, you said 12 and up. Is there an age cap at the other end? Can people in nursing homes receive this treatment?
Absolutely. We're doing that now, and we're going to probably start doing the subcutaneous route on several of them when one of their clients gets infected. So nursing homes, can get wiped out pretty quickly, and we are using this. And going to use it.
Now, is this something you receive one time, or do you need to receive it multiple times?
No. So the infusion is one time. If you get the subcutaneous route, you're sitting in a chair, and it's 4 shots at the same time. Basically, they do 2.5 cc's, say in one arm, 2.5 cc's in the other arm, and then 2 legs. So it's one setting. You don't come back. It's one and done.
Jumping again on that pre-existing condition question, excuse me, got somebody asking, and again, you would be the expert here. She said, what if I have COPD? Can I still get it?
I'm a COPD doctor. I give a lot of my patients COPD. There's no reason not to. Those are reasons to get it, not reason not to get it. If you
What
got
about the
if you have COPD, you do not want to have get sick from COVID. This, Lord willing, will prevent you from going to the hospital or emergency room.
And what about those same people with COPD, with asthma, with other breathing problems, and the vaccines? Are you recommending vaccines for those people as well?
Absolutely. They're the ones that need them more than anybody. I want to tell you one little thing about asthma, just interesting. At the very beginning with that people with asthma, they gonna get it really, really bad. Then we started noticing, well, they didn't get it really bad. And then we started looking, well, why? Well, most of my asthmatics are on inhaled steroid or a combination of other drugs. And one of the things I use from day one, whether you have respiratory problems or not, is start you on an inhaled steroid called budesonide. Through a nebulizer is what I do. I don't give oral steroids, oral prednisone or meterodose pack or steroid shot, but I do give inhaled. It protects the lungs, and just some recent studies came out that shows it decreases the chance to go in the hospital and cuts the infection symptoms down by 3 or 4 days. So that's what they asked the connection, how we found out about that.
That's fascinating. And I know, again, we've gotten so many questions here. I'm trying to get to the ones that are kind of encompassing most information here. And this is a good question because you say that you need to get this treatment within 10 days, ideally the first 5 of having your first symptoms. Debbie says, well, what if I don't have COVID, but I'm a healthcare worker and I want to get on the front end of this? Could I get this treatment even if I don't have COVID and it kind of help prevent COVID?
You have to have some exposure. Okay. Now, having said that, I was called last week by, I better not name the hospital, but a big hospital. Half of the infusion nurses were out with COVID. Okay. And they said, if I lose the other half, I'm out of business. Well, it just so happened I could say, well, they were all exposed because they're in a COVID unit. So I infused them, okay, to give them a 60-day protection, if you will. You know, this is pretty much out of your system in 60 days. So that did that. And that's kind of out of the box. Okay. You won't read that in the instructions, but we're just having to do what we have to do right now to keep our workforce intact.
So again, and I know that I have a few people saying they missed the beginning of this video, and Joan says, is this suggested before COVID or once you have COVID? So Joan, this is suggested when you get COVID within 10 days of your first symptom. So Dr. Thrasher was saying the day that you get your test is not as important as the first day of symptoms. So that just kind of reiterates the point of you need to get tested as soon as you start thinking you could have been exposed or have symptoms.
Let me comment on that. Okay. Now, if you've been exposed, now don't go run out the next day and get a test because it may be false negative. You know, what I say, you know, if I'm talking live to you, Ivana, and you call me tomorrow and say, well, I've got COVID. What I'll do, I will kind of quarantine myself for 4 days. I can get tested in 4 days, but don't get tested before 4. We used to say 5, but this is so contagious, usually 4 days. Now, if you start having symptoms, you get tested then. But if asymptomatic, wait 4 days, or you may be fat and happy and think you don't have it, and you do.
Now, I know that this, again, is something, it's not necessarily a new treatment, but it is just now becoming a little bit more publicized. I feel like we just started hearing about it in the last couple of weeks. So we know that it's available fairly widely. Do you worry that there could be a kind of shortage on places to get this treatment as more people learn about it and as more people discover how effective it is?
Dr. Saget, UAB, and I started setting up infusion centers and encouraged them all over Alabama last January and December, January, February. And so we've got the infrastructure there. We're trying to expand it. Now, you've probably seen the Florida commercials and Governor Abbott in Texas, you know, talking about the drive-by places, this and that. We've done that. We're actually a year ahead of them in Alabama. We've given more monoclonal antibody infusions per capita than any state. That was the data last year. I haven't been up to date lately, but we've given a lot here. We're trying to expand it. My Achilles heel is nurses and respiratory therapists. When the governor gave us the Emergency Authorization Act last week, that helped a lot. Now we're going to put EMTs and other people to be able to help give the treatment. It's a personnel problem, not a supply. And I've got the facilities. I just need more people to work there.
I think that that's something, again, we've heard from the state. I'll give you a couple of quick questions, and I know you're a busy man. 2, I'm going to combine. 1, this is, again, saying who can get it. I got one person who says, what about if I'm obese? And one person who says, what about a person with alpha-1 who has infusions every week?
Okay, obese, the person who's going to do very poorly if they get COVID is the obese, okay? The particularly young people, the ones, the 40-year-olds, the 20-year-olds, and the 30-year-olds. If you're really obese, it's not good. Hopefully you'll get vaccinated to prevent it, but they're the ones that really need the infusion. Alpha-1, they get infusions each week. You know, I've not done an Alpha-1, and I won't tell you anything unless I'm 100% positive. I know the Alpha-1 needs it if he gets it. Now, whether it will interfere or delay the current infusion, I don't know. UAB would know that, but I don't think it's a problem.
And we appreciate the questions here. And I know that something that we've really found is that there are so many people who don't have a direct line to somebody who is a doctor or medical provider. So we appreciate you taking these direct questions here to kind of educate people, help everybody get their information. Doctor, one more question, and that is, what if I'm vaccinated and I get a breakthrough case? Can I still get this treatment? Or is this treatment only for unvaccinated people?
Great question. I don't know how many hundreds of patients, exactly that same scenario. I got vaccinated before, it takes about 6 weeks to get fully protected when you're vaccinated. We have a lot of breakthrough infections in that 6 weeks. Yes, I'll go immediately infuse them and then wait 30 days for their second vaccine shot.
Dr. David Thrasher, you are located in Montgomery. I know that you operate at several different places in Montgomery. So tell us where people can find you, and also tell us where people can find a treatment center for monoclonal antibody treatment.
Well, I got a 10-man group, and we're really, really busy in the hospital, taking care of all the ICU patients as well as all the patients outpatient. We're here. The Medical Association State of Alabama has a website. Call them for centers in your area. The Department of Public Health has also, you can call them and ask, where can I get a monoclonal in Florence, Alabama, Dothan, et cetera. Those are all listed there.
And we will.
You've got a treatment protocol. I would encourage you, if anybody asks you, feel free to disseminate that, because I want people to know what they should and should not use.
Absolutely. And I've got it here. I had it printed out. I have an email file. So if you need it, please email me. It's iHerenQ@AL.com. Dr. Thrasher, thank you so much for your time. I know you have more patients than you would like. So we're going to let you go and get back to them. But again, thank you so much. Everybody watching, thank you so much. We'll see you tomorrow.